back in 2006, along with Natarajan sir. Many of you may be aware of him. He's one of the best speakers we have in the country, both in interventions as well as EP. And I used to religiously attend his talks and topics as a DM resident myself. Later, I had the fortune to work with him for almost 2 years, and he's also one of the best mentors I've ever had. So you'll see how good his talks are in a short while. And over to you, sir.
Thank you, Dr. Mugul. At the outset, I thank Medtronic for having arranged this web-based session, which they have been doing in the form of a series of talks. And today's talk will be on troubleshooting in patients with an implanted cardioverter defibrillator. We will make it as case-based an approach as possible instead of making it a theoretical discussion. I understand that most of the participants are interventional cardiologists or students who are in the process of learning the basics of troubleshooting of devices like ICD and pacemaker. So I will be a little basic in most of the presentation today so that everybody follows. If some of the experts are here, I apologize to you. So the ICD system, as you know, has the device which is capable of pacing as well as monitoring from beat to beat monitoring of the cardiac rhythm, identifies high rate as programmed for detection by the device. The device is connected to the heart through a lead, like the pacemaker lead, which in addition to the usual pace sense function of a pacemaker lead, also has a defibrillator coil for the purpose of delivering of high voltage shocks, either for ventricular tachycardia or ventricular fibrillation, as the case may be. So in the next 45 to 50 minutes, we will briefly touch upon the basics of ICD function, how it works in terms of detecting a ventricular arrhythmia, how it treats a ventricular arrhythmia, how do we interpret stored vital data which are stored in the device itself that will help in identifying the problem. Should there be a problem, how a stored information in the device when the patient comes to us for follow-up helps us to understand what is the problem, is everything okay, is something appropriate, is something inappropriate, what exactly is inappropriate. So the stored information in the device helps us to a large extent in identifying the problem. So we will also go through how to interpret this stored data. Along the course of the talk today, we will go through a few typical case examples of issues during follow-up of patients with implanted cardioverter defibrillator. We will also see how to identify these problems as we go along, and how the current generation devices have come a long way in contrast to the previous generation of devices in timely delivering alerts to significant problems with device function, and also in avoiding undesirable device therapy. So the modern day devices to a large extent alleviates our problem of having to painstakingly go through the device function, finding out what went wrong, patients coming with repeated inappropriate therapy, for instance. All that to a large extent has been obviated by developments in device technology, which we have the luxury to handle as of now. However, though the devices have all these functions, it's good to know how these devices use these smart technology to avoid the problem, because it gives us the opportunity to understand the device better, which will go a long way in identifying trouble and also to shoot trouble should the trouble happen. If you look at the ICD therapy cascade, the step number 1 is sensing of the arrhythmia. How does it do it? Like a pace sense lead. It constantly monitors the cardiac rhythm. So it identifies the exact ventricular electrogram where it is in contact with the myocardium. It goes by how does it detect an arrhythmia? The step number 2, it detects an arrhythmia primarily by looking at the rate. If you say, if the ventricular rate is more than 200, you treat it like a ventricular fibrillation. When the rate is more than 200, it treats like a ventricular fibrillation, unless there are some other reasons to abort the therapy. So sensing is very vital. Detection of the arrhythmia is primarily based on rate, the number of intervals needed to detect the arrhythmia. It can be ventricular tachycardia, it can be fast ventricular tachycardia, it can be ventricular fibrillation, but all that is primarily derived by the number of intervals belonging to a particular predefined rate that we program. After having sensed and having detected the arrhythmia based on this rate criteria, the next important step is to discriminate between a ventricular versus a supraventricular tachycardia. For example, there can be a patient with an atrial tachycardia with a rate of 200 per minute, which is the rate we have kept for the ventricular fibrillation as well. But we don't want a shock to be delivered for a more benign supraventricular arrhythmia. So the most important third step is to differentiate between a ventricular tachyarrhythmia versus a supraventricular tachyarrhythmia. If it's a ventricular tachyarrhythmia, the therapy is delivered. If there is an SVT, the therapy is inhibited. If it is a ventricular tachycardia, the therapy is delivered, which can be an anti-tachycardia pacing or a high voltage therapy like a shock, as the case may be. So these are the important sequences in which an ICD functions to treat arrhythmias. We classify zones basically by the rate itself. This is a ventricular tachycardia zone. This is a ventricular tachycardia which is little faster. We can use the word fast ventricular tachycardia zone, and a very irregular, very rapid tachyarrhythmia, that is ventricular fibrillation. You can program a single zone device where you have only ventricular fibrillation. You can have a two-zone device with only one VT as well as one ventricular fibrillation. You can have three-zone where you can also incorporate a second ventricular tachycardia. So these are the various zone classifications for detection purposes, primarily driven by the rate. As you can see here, if a tachyarrhythmia falls in this zone, this is the VF zone, this is the VT zone, and this is the sinus rhythm zone. And here are the numbers given in cycle length. Lower the cycle length, more rapid is the rate. So if an arrhythmia were to be confined to this level, it will be classified as a ventricular fibrillation, and it will be marked as FS, meaning fibrillation is sensed. To the contrary, if the rate is a little slower but still faster than the sinus rhythm zone, for example, at this level, it is slower than the ventricular fibrillation but faster than the sinus rhythm zone. So this falls in the ventricular tachycardia detection zone. So that interval, that longer RR interval than the VF, will be categorized as a ventricular tachycardia sensing, which will be labeled as TS. These annotations are very important for us. Hello? Sorry. So if the rate is a little slower than the ventricular fibrillation but falls within the VT zone, it will be marked as a tachycardia sensing. TS stands for tachycardia. Mukund, I am audible, right? Hello?
You are audible, sir. You are audible, sir.
Yes, sir, you are.
So I was getting a call. I thought one of you was calling me to tell that I'm not audible. Sorry. So that is FS stands for ventricular fibrillation sense, and TS stands for tachycardia sensing. If the rate is still slower and falls within the range of the expected sinus rhythm of such a long RR interval, it will be labeled as V-sense, or sensing of a rhythm in the sinus rhythm zone. So this is basically the way the ICD functions. There is a VF zone, there is a VT zone, and there is a sinus rhythm zone. If you see carefully how the device classifies as a sinus detection or a tachy detection or a fibrillation detection is by the RR interval, which has been programmed to the device. If you look at this basic setup here, we have pacing function on top here, AAI to DDD pacing function, the rate, all that you can find out by going into this window. And this is the tachycardia detection. This particular case has been programmed to a two-zone device, a VF zone as you can see here, which is on, and the cycle length for VF detection is 320, which is 188 beats per minute. These are the intervals which we are giving as a criterion. 18 out of the 24 intervals if it belongs to this particular cycle length, it will be classified as a ventricular fibrillation. And this is the therapies which have been programmed for that EF. Fast VT is kept off here. So this is a 2-zone device. The next zone is a ventricular tachycardia. 400 milliseconds is the detection cycle length, which is 150 beats per minute. And what is the therapy program? ATP, anti-tachycardia pacing 3 bursts, followed by low energy to higher energy levels for cardioversion of the ventricular tachycardia. So this is how we program the pacing function of the ICD, as well as the tachycardia detection, as well as the therapy. So in terms of ICD troubleshooting any device, whether it's a pacemaker or an ICD, consists of evaluating the entire system. There are 3 components to the system here. One is the patient himself or herself. We should have an idea about the indication for the ICD, the drug treatment the patient is on, changes in the substrate of the patient, whether there is worsening of LV dysfunction, newer myocardial infarction with added scar substrates, concomitant disease states. These are all patient-related factors which are very important during follow-up. The next is the device itself. What are the program settings? We just saw in the previous slide, detection criterion, pacing criterion, therapy criterion, all that we saw, that they are the program settings of the device. We should have an idea about the battery status. If the battery has reached end of its service, it will not function. Not to forget the third important component of the device system, which is the thing which connects the device to the patient, that is the heart, that is the ICD lead. There can be changes in the tissue interface, the lead tissue interface, there can be a problem. There can be an exit block where the lead is in contact with the myocardium. The sensing of the local voltage may be inadequate because of this kind of fibrosis, etc. That will lead to undersensing of a ventricular tachyarrhythmia, so on and so forth. Insulation defects, conductor fracture, like the pacemaker leads, they can complicate the ICD leads also. So all these 3 components are very important when we follow up patients with implantable defibrillators. Regarding ICD troubleshooting, some issues are more common at different points in the lifespan of the device. For example, one can be at the time of implantation itself. You may not be able to defibrillate the DFT. The defibrillation threshold may be higher. You may not get good sensing voltages in a place where you are screwing in or you are fixing the lead. So there are problems which happen during the implantation. The next is immediate post-implant. Everything went on well. The next day you have a problem. It may be a lead displacement. It may be some suboptimal connections between the lead and the device due to a loose set screw. They happen in the immediate post-implant period. And the last thing is chronic, during long-term follow-up, which will be the focus of our presentation today. So during follow-up, what are the problems which can happen? The arrhythmia may not be detected. We say it is failure to detect the arrhythmia, or the arrhythmia has been detected, but the therapy is not getting delivered. We say it's failure to deliver therapy in spite of detecting the arrhythmia. The third is the arrhythmia has been detected, the arrhythmia has been treated, but the arrhythmia does not convert. That is another problem. Then multiple shocks, a patient receiving 3-4 shocks in a span of 15 minutes. We use the term multiple shocks. And most important thing about shocks is the shock can be appropriate. It can be a VT or a VF, and the shock was appropriate to the, that is the very idea of implanting the device itself. So appropriate shocks versus the most important differentiation should be whenever a patient comes with a shock to our follow-up clinic, the first and foremost exercise that we have to do is to find why the shock happened. Was it for an appropriate reason or is it for an inappropriate reason? So these are some of the important problems that can crop up during the course of follow-up. And regarding a few words about inappropriate therapy, this can be due to supraventricular tachycardia like simple sinus tachycardia, atrial fibrillation, atrial flutter with rapid ventricular rate, paroxysmal supraventricular tachycardia like AV nodal reentry, AV reentry, etc. Or it can be due to a lead fracture, which causes, if there is a conductor fracture in the lead, there is something called make-break contact. During the process of friction between the fractured conductor coils, this can generate abnormal fast signals because of this, and that is called noise. And the device will unnecessarily treat it like a ventricular tachyarrhythmia. So lead fracture causing noise is another important reason for inappropriate therapy. and of course T wave of oversensing. Let us say the QRS, the R wave is counted as one activity and the subsequent T is also counted as another activity. So for every ventricular depolarization, two signals are counted. So if the ventricular rate is 90, it will be perceived as 180. We call it T wave oversensing. This also can be a reason for inappropriate therapy. And of course, electromagnetic interferences can also cause abnormal signals which can be sensed by the device as a ventricular arrhythmia. So these are all situations where there is no ventricular arrhythmia, but the device can detect plus minus treat like a ventricular arrhythmia, which can be a reason for inappropriate delivery of therapy. Earlier generation ICDs were limited in their functional capabilities. Discrimination of SVT from VT to VF was not that very perfect. Discrimination of noise from ventricular fibrillation was either not possible, or even if it is possible, it was not sufficient enough. Oversensing of T waves was a definite issue. A lot of these patients with the previous generation ICDs 20 years back will have inappropriate shocks due to T wave oversensing, double counting of a QRS complex. Anti-tachycardia pacing was not possible in the ventricular fibrillation zone. That was a serious limitation in the previous generation ICDs. And this led to high incidence of painful shocks, and many of them were even inappropriate shocks, and that is not a good thing. Fortunately, now the technology has advanced so much that we have newer generation ICDs that have built-in features to obviate many of these limitations. Like, for example, even if they have all these features, that doesn't mean that we should not be aware of what is happening. We have to be aware of these additional features, identify normal versus abnormal function, understand proper interpretation of real-time and stored data. When I say real-time, a patient has come to our follow-up clinic. You are interrogating the device and collecting data then and there with the patient sitting in front of you. It's called real-time data. Stored data is past information which has been recorded in the device, which also we can retrieve and see. And based on what we find, we can reprogram the device. For example, if there is a lead fracture causing noise, you have to revise the lead itself. Let us say the battery voltage has come down, we'll have to change the pulse generator. Patient has frequent appropriate shocks, we may have to modify the antiarrhythmic drug therapy or subject the patient to a radiofrequency ablation to modify the substrate so that it can reduce the chances of the arrhythmia recurring in future. So these are some of the important differences between the older generation devices and the current generation devices and where we stand today. A few words about stored information. A patient has come, you have interrogated the device, you go to the stored information. What do you look in the stored information which will help you troubleshoot? You can look for certain observations. The device immediately gives a column saying observations, interesting observations, which the device highlights to the implanting physician who is following up the device. You can look for alert conditions. For example, if the device lead impedance suddenly jumped from 300 to 2500, this will give an alert. So when you interrogate the device, you will find that there is an alert due to an abnormally high pacing lead impedance. So these are some of the observations and alert conditions. We will come to all this with typical case examples. You can look at the pacing trends. How many times what is the percentage of ventricular pacing? What is the percentage of atrial pacing? What is the incidence of atrial arrhythmias? What has been the R wave amplitude? What has been the atrial sensing amplitude? The lead impedance trends. What was it before? What is it now? Is it steady? Is there any acute change in the lead impedance? Arrhythmic episodes, a very important thing. It will tell you this patient had this many episodes of ventricular tachycardia, this many episodes of ventricular fibrillation. You can always, somebody says he can't see my slides. Is the slide seen, Mukund, Venkat? Venkat?
Sir, I can see
Yes, like
Somebody said they can. Are you able to see? Okay.
Yes, sir.
If there is anything, Mukund, please interrupt me, okay? Because I have no two-way communication, right? So, arrhythmic episodes are also stored in the data bank of the device. We have electrograms which are stored. We have interval plots. We will see the details. we have text of the episode. All this gives you information about whether the shock was for the right reason or for the wrong reason. And of course, when the patient is right in front of you, you can also do real-time interrogation of the device. You look at the battery status, the pacing lead impedance, shock coil impedance, the R wave sensing amplitude, the P wave sensing amplitude, the pacing capture thresholds, like you do for a pacemaker patient. All this can be done, stored information and real-time interrogation of the device. And of course, the last is a non-invasive EP testing or a defibrillation threshold checking. We reserve it for selected cases. We won't go into the details. This is a quick look screen on initial interrogation. A patient has come, you have interrogated. This is the screen which first appears in front of you. You call it the quick look screen in Medtronic devices. It is called the fast pathway summary in a Senju device. Each company calls it by a different word. Quick look is a trademark of the initial screen of a Medtronic device. You see all the data is available for you. Look at the pacing lead impedance here, atrial pacing lead impedance, ventricular pacing lead impedance, the atrial capture threshold. In this device, for some reason, the RV threshold is not mentioned here. The P wave amplitude, the R wave amplitude, the percentage of pacing. This patient has never required pacing. 99.9% is atrial sensed ventricular paced rhythm. This gives you an idea about ventricular tachycardia, ventricular fibrillation, or atrial arrhythmias that are treated by the device. None in this particular case. Monitored episodes. Monitor meaning collect the data but don't treat. That's called monitored. You keep a slow VT usually as a monitor. If you see that, there is one episode of a slow VT which has been monitored by the device. The VOS stands for ventricular oversensing. 2 episodes of ventricular oversensing. If you look at the observations, it says P wave episodes have been detected. RV lead noise warning has been delivered on this particular date, so on and so forth. So much of vital information you get from the quick look data. Now let us look some of the important observations. That's not the same patient, this is some other patient. What I wanted to highlight was, look at the atrial pacing lead impedance trend over a period of, this is in 2006, this is 2009, 2010, this is in February 2010. Over a period of nearly 2 years, if you see, we started with the lead impedance of about 450, which is normal. We suddenly find that the lead impedance has become very low. So this is a vital information that you have gathered by looking at the pacing lead impedance trend. And this is because of a lead problem. In the atrial lead problem, it's an insulation failure. So that is the importance of looking at this particular trend. If you look at the ventricular pacing lead impedance trend in yet another patient, it was normal to start with. Unlike the patient where the pacing impedance came down, you see there is an acute rise in the threshold, rise in the pacing lead impedance. So you know you're dealing with a fracture of the lead, pacing lead, the ICD lead conductor fracture. So this is some of the important data that the device provides you during the time of follow-up. So let us understand a few concepts. Leadless ECG, atrial electrogram, near field ventricular electrogram, and far field ventricular electrogram. It's very important to understand this, though even if I don't manage to finish the entire presentation in the next, in the allotted time, I want you to understand what exactly we are discussing. Even if we finish only 30% of the presentation, it's okay. But that entire 30% we should understand as much as possible. Each word is very important. I want to draw your attention to these 2 important things. Near field ventricular electrogram and far field ventricular electrogram is very vital to our device follow-up, as we will see later. I just want to introduce the concept called near field EGM and far field EGM at this particular stage. If you look at all these things, this is a real-time device interrogation. On top you see what is called the leadless ECG, which takes information from the CAN to the SVC coil. It says ASVS means atrial sense ventricular sense rhythm during the time of interrogating the device. The EGM1 is the atrial near field or atrial electrogram that you see here. That is from the atrial tip, the tip to the ring electrode of the atrial lead. EGM3 is the ventricular electrogram. This is the near field ventricular electrogram because it is marked here, ventricular tip to ventricular ring. That is the near field ventricular electrogram. The fourth one, if you see here, it is also a ventricular electrogram, but is recorded between the CAN, the active CAN of the device, and the RV defibrillator coil. This is called a far field electrogram. So this is a leadless ECG. This is an atrial electrogram. This is a ventricular near field electrogram because it is tip to ring. It is right at the tip of the electrode of the lead. So it's a near field electrogram. Can to coil is a big distance. So it gets a lot of additional information. That's why we call it a far field EGM. So that is the leadless ECG, the atrial electrogram, the near field ventricular electrogram, and the far field ventricular electrogram. A few words about near field and far field. If you look at this, this is the tip electrode, this is the ring electrode. So if anything is detected here, if any signal is picked up by this bipole, you call it a near field electrogram. Tip to ring, or in some Medtronic devices, it can be tip to coil as well. But nevertheless, the tip is involved in the sensing process. So this is called near field sensing. And if you see the electrogram morphology of the near field electrogram, there is hardly any difference between the electrogram in sinus rhythm as against a ventricular tachycardia. The near field signal is always a sharp signal. It does not differentiate between a supraventricular rhythm versus a ventricular rhythm. It is only meant for sensing in terms of identifying the rate. It does not care whether it is supraventricular or ventricular. It only says the rate has jumped from 60 to 220. So I will call it a ventricular arrhythmia. So near field EGM is used for the purpose of sensing. That is very, very important information. And what is the near field? It is either the tip to the coil or tip to the ring or tip to the coil. That is, the electrograms are no different between supraventricular and ventricular. If you look at the far field EGM, let's say that the next EGM is from the CAN to the RV defibrillator coil. The coil is here, the CAN is here. If an electrode is generated by using these two poles, the CAN as a pole and the RV defibrillator coil as a pole, you get a wider information, and that is why you use the term a far field electrogram. And far field electrogram, interestingly, if you see, if the far field electrogram in sinus rhythm is like this, we look at the far field electrogram during ventricular tachycardia. It is distinctly different. It is very, very broad. You can see this broad, and the sinus rhythm is relatively narrow. So the near field electrogram does not differentiate between supraventricular or ventricular. It only counts the rate of the rhythm where it is in contact. It tells 50, it tells 170, it tells you 190, 250, so on and so forth. It does not give you any extra information beyond that. Whereas the far field EGM has a morphological difference between a supraventricular rhythm versus a ventricular rhythm. Somebody says audio is not there. I suppose I can heard. Mukund? Mukund, can you hear?
Well,
okay, fine.
yes,
So,
sir. Yes, sir. I can hear.
fine. So the far field EGM is not used for the purpose of sensing. I want to underline the fact the far field EGM is not meant for sensing. It is only for these kind of discrimination. It is used to discriminate between SVT and VT, and also for noise detection, about which we will come to when we see a case of noise related problems. So I hope you are clear about the near field and far field. Near field is between the tip to ring or tip to coil. It is only for sensing purpose. It only counts the rate. Of course, it has to have a good electrogram where it is in contact. So it only goes by the rate. It is the primary sensing pole or sensing electrogram that is used by the device for detecting an arrhythmia. Far field is from the coil to the CAN nominally, and that is different between a supraventricular rhythm and a ventricular rhythm, and it can be used for discriminating purposes, not for sensing the arrhythmia or discriminating the arrhythmia from one to the other. Now we go on to study the EGM, marker channels, and interval plot before we go to the cases. If you look at this marker channel, if you look at this is the EGM or the electrogram of a ventricular single chamber ICD. You can see rapid activity going on. The marker channel tells you how the device interprets each signal as. How does it interpret? It goes by the cycle length or the interval between the consecutive sensed beats. You look at this, it comes in the window of fibrillation because you have told that ventricular fibrillation should be less than 300 milliseconds is ventricular fibrillation for my patient. It is less than 300, so it says FS. FS stands for fibrillation sense. PS stands for tachycardia sense. That is the importance of the marker channel. This is the EGM and this is the marker channel. TS stands for tachycardia sensing. FS stands for ventricular fibrillation sensing. And this is once it qualifies the criteria to detect an arrhythmia. For example, if 18 out of 24 beats fits in the ventricular fibrillation, it says STIB detected, as you can see here. This is STIB detected. This is tachycardia detected. This is fast ventricular tachycardia detected. This is depending upon the number criteria that you have given, NID, or the number of intervals needed to detect. So 200, the tachycardia should be faster. It should also have a sufficient duration for it to be detected and to be treated. I just want you to highlight on the electrogram on top and the marker channel on the bottom. This is the atrial sensing by the atrial channel. This is by the ventricular channel because this is of a dual chamber ICD. Moving on to therapy. You see here, CE stands for ending of charging and CD stands for delivery of the charging, and the ventricular fibrillation has been successfully converted back to a slower rhythm. So this is the EGM, this is the marker channel, on top is the atrial sensing and the bottom is the ventricular sensing. You can clearly see the AV dissociation that we talk about in the ECG in ventricular arrhythmias. The ventricular rate is much faster than the atrial rate incidentally. The basic principles of ECG apply to all devices. It applies to the field of electrophysiology as a whole. So if you look at this stored diagnostic information for patient management, this is the atrial EGM on top. This is HVH being far field. This is the far field ventricular electrogram, and this is the atrial marker channel, and this is the ventricular marker channel. If you see here very clearly, there is a very rapid atrial arrhythmia, even faster than the ventricular arrhythmia, and these are the intervals which have been noted down here. The interval is 200 in the atrial channel, and in the ventricle it's about 400. So in one look, you can tell that it is likely to be an atrial flutter with 2-to-1 conduction. Half of the atrial rate is the ventricular rate. So rapid ventricular detection, rapid, but half the atrial detection rate on the ventricular channel. 200 is the atrial intervals, 400 is the ventricular intervals. Nevertheless, it falls in the tachycardia interval, and so it is called TS. Tachycardia has been sensed in the ventricular channel. So this is the importance of stored information. A word about interval plot. Interval plot tells you, if you look at the y-axis, you have the intervals from 2000 on top to 200 below, meaning as the rate of the rhythm increases, it will be, the cycle length will be lower and lower. And if you see these pink dots that you see here, these are the individual beats in the ventricle. And this horizontal line tells that below this line, you should treat it as a ventricular fibrillation because the cycle length is 320. So anything below this will be a ventricular fibrillation. Anything on top of it will not be a ventricular fibrillation. And if you can see these intervals here, they fall at a rate which is above lesser than the ventricular fibrillation rate. You see, suddenly the rate has increased or the cycle length has decreased to the VF zone that you see here. And this device is rightly classified as a ventricular fibrillation, delivered a 24 joule shock, and the arrhythmia has been converted because you see these dots here, they have come above the line. So faster the rhythm, lower the cycle length, slower the rhythm, longer the cycle length. From a slower rhythm, abrupt transition to a faster rhythm, which comes in the bracket of ventricular fibrillation detection. Appropriate shock is delivered and the rhythm has been converted. As you can see here, the heart rate plot is above the detection window of ventricular fibrillation. So this is called interval plot. This is the stored EGM of the same patient, as you can see here. This is tip to ring. So this is near field ventricular electrogram. Can to this is the can to the RG coil. P stands for below. So this is the RG coil. You can see this is the far field EGM happening at a very fast heart rate. And what does the marker channel tell you? fibrillation sense because it comes in the fibrillation window. So it is sensing as a fibrillation. FS stands for fibrillation. It is qualified to be called as a sustained rhythm. Fibrillation detected. The device will charge. The charge has ended. The charge is delivered, and the rhythm has been converted to sinus rhythm. Right. So that is the importance of these stored EGM and all these marker channels and various annotations, both in the atrial channel as well as the ventricular channel. If you look at this interval plot, the green squares are the atrial beats, as you can see here. The atrial sense activity is the blue boxes, and the pink ones are the ventricular boxes. Both are the same because it is likely to be sinus rhythm. And there are two lines here because there are two zones which have been programmed here. Between this line to this line is ventricular tachycardia, and below this line is ventricular fibrillation. If you look at this rhythm here, all of a sudden, if you see, the atrial rhythm remains the same, but the ventricular rate has become very fast, and it is falling within the ventricular tachycardia detection zone. It is not fast enough to come in the ventricular fibrillation zone. It is in the ventricular tachycardia zone. And what you see here is an anti-tachycardia pacing sequence. 8 pulses of anti-tachycardia pacing at a rate which is faster than the tachycardia rate. And what you see at the end of anti-tachycardia pacing, the ventricular tachycardia has been converted back to sinus rhythm, and the ventricular rate is now matching that of the atrial rate. This is another example of an interval plot. Both are the same. Atrium and the ventricle are slower here. Suddenly you see that the ventricular rate has become very rapid, and this falls in the ventricular fibrillation window. And what has happened thereafter? A 34 joule shock has been delivered, and the tachycardia has been successfully converted, and the atrial P and the QRS are now having a one-to-one relationship. This is called an interval plot. So with this basic information of identifying the stored electrogram, understanding an interval plot, understanding the difference between a near field EGM meant for sensing the rate versus a far field EGM, which is from the coil to the can, which is primarily not used for sensing but for discrimination, and the various zones that we program: ventricular fibrillation, ventricular tachycardia, fast ventricular tachycardia, the rate cutoff that we program for each zone, and the therapies that we have programmed. This sets the foundation for going through a few cases as to how to troubleshoot these patients when they come for follow-up. The first case is a patient with a single chamber ICD. The RV sensing polarity was programmed tip to ring. That is the usual. That is a fallback near field sensing that is normally kept. During routine interrogation, the measured R wave was found to be very low. It was only 3 millivolt. What are the consequences of this R wave being low, and what are the solutions? If you look at the R wave amplitude, it has become 3 now. So what has been done is the sensing polarity from tip to ring has been reprogrammed in this particular case to tip to coil. Tip to coil is also a near field sensing. This is possible only in the Medtronic devices. So from tip to ring, as I told you, it was tip to ring. The sensing voltage was low in the tip to ring, and the minute you made the sensing configuration as tip to coil, you see that the R wave has improved to 12. So you are now using the sensing polarity to our advantage to prevent under-sensing of a ventricular arrhythmia. The consequence of having a 3 millivolt ventricular sensing is the fact that during sinus rhythm it may be 3 millivolt, but when the patient develops a ventricular fibrillation, it can be very, very small, and the tachycardia may not be detectable by the device. By improving the sensing amplitude to 12 millivolts, you are now very comfortable. However low the ventricular EGM becomes during a ventricular arrhythmia, it will still be with the safety margin of ventricular sensing. So this is an example of changing the sensing polarity to our advantage to improve the sensing amplitude from a low value to a very desirable value. The case number 2 is a single chamber ICD implanted in December 2000. These are all historical cases. December 2005, a single chamber ICD was implanted. This patient came 2 years later after multiple shocks. So this is a quick look that we originally alluded to. What do you see here? Forget about the battery. We'll only look at the relevant points here. This patient has been treated for VT or VF 9 times. This patient has been monitored for VT, not in the treatable range, but in the monitorable range because it is a slower VT. See the number of ventricular tachycardias this patient has had. Monitored 354 episodes have been monitored. So multiple ventricular arrhythmia burden this patient has. If you look at the lead parameters here, the pacing lead impedance is close to 3000. So one look at this quick look, we know that there is a problem in the ICD lead conductor coil is likely to have a fracture. It's very likely that there is make-break connection problem. So there is noise which is created by this abnormality, which is sensed by the device as a VT or a VF. Some have been monitored because they are at a lower rate. Some have been treated inappropriately. So this patient is likely to have had inappropriate shocks due to a lead conductor fracture. And as you can see here, if you see the lead trend in this particular patient, you see that at a particular point in time, the conductor fractured and there is an acute rise in the pacing lead impedance. And if you look at the interval plot in this patient, from a low rate here, you see it is all over the place. It is in the VT zone, it is in the fast VT zone. This is a 3-zone device, VT zone, fast VT and VF. It is all over the place, multiple kind of RR intervals happening in the same episode, grossly irregular pattern. Even a ventricular have this kind of an irregular pattern. And what is more interesting is some of the intervals are even around 100 milliseconds, not 100 milliseconds, around 120 seconds. Very, very, very short RR interval during the so-called arrhythmia. This is very typical of noise. All over the place, ultra short RR interval, almost like 120 milliseconds, 130 milliseconds. You know that this is unlikely to be a ventricular fibrillation. But this device has no way of differentiating the two, and so it has delivered a 36 joule shock. It has not terminated. Some changes have happened which are not actually, and it is likely to happen once again later on. What happened here may happen again after 10 minutes. That is why this lady had multiple episodes. If you look at the electrogram, this is the tip to ring, the near field ventricular electrogram. This is the far field ventricular electrogram. You see there are multiple unnecessary signals being sensed by the near field electrogram. To the contrary, if you see the far field EGM, it is very clean, pristine far field signal. But the device will only go by what is counted by the near field electrogram. This is what is reflected in the marker channel, not the one which you see in the far field channel. This is all important because the current day devices use this observation to its advantage. If you see noise in the near field electrogram, but you don't see such noise in the far field electrogram, the device will diagnose it as a noise and it will not give therapy for the ventricular tachyarrhythmia. That is the advantage of the current generation device. This device does not have that luxury because this is an older generation device. The noise discrimination algorithm is not there. So the near field shows rapid activity, which has been sensed in the ventricular fibrillation zone. These are the intervals. See, some of the intervals are 150, 130, very, very ultra short. But the device has classified it as a ventricular fibrillation. It has detected and it has delivered a therapy also. So this is an example of a noise. I want you to again remember that the noise appears in the near field EGM and not in the far field EGM. So one more advantage of the far field EGM, which can be used and it has been used already in the newer generation device, is to differentiate between noise and true ventricle. If there is a fast rhythm here and a similar fast rhythm also in the far field, it is a true ventricular arrhythmia. To the contrary, if there is a fast rhythm which is identified here, it is not reflected here. That means this is an artifact. This is a noise. And the current devices go by the discordance between the near field and the far field, and they will abort therapy. But it will give an alert. There is a noise. You go and meet your physician. He has to change your lead, but it will not deliver an unnecessary therapy for the patient. The other important advantage, as I already told you, is to differentiate between a supraventricular rhythm versus a ventricular rhythm, about which we'll come to a little later. The third case, A single chamber ICD implanted in February 2011 presented for evaluation in view of the patient received an alarm. Alarm meaning a sound which comes from the device at a prescribed time, telling him that there is a problem, go meet the physician. Or it can also be done by remote monitoring using the current day remote monitoring devices. The clinician will be alerted even without the patient having to come to the clinic. So this patient had a single chamber ICD implanted and he had an alarm from the device 6 months later, and so he comes to the physician and says that he had an alarm from the device. You look, when I say alert, there are some alert criteria that you are programmed on. If the lead impedance goes out of range, you have to give an alert. These are all alerts which are programmed based on what we need. Low battery voltage will give off an alarm. Excessive charge time will give an alarm. Number of multiple shocks delivered in a single episode, if you switch it on, it will give an alarm. All therapies in a zone exhausted for an episode, here it is programmed off, you can keep it on. Likewise, you have RV lead integrity alarm, RV noise alarm in current day devices. So these are all the alerts which can be programmable. For some reason, this patient received an alert which may belong to one of these reasons. Let us find what the reason is. The reason is RV lead integrity alert. There is something wrong in the RV lead, and this patient also had 19 monitored ventricular tachycardia episodes. So multiple non-sustained tachycardia episodes have been monitored by the device, and there is also an RV lead integrity alert which has been given. Let us find out what went wrong here. The RV pacing lead impedance is normal. It's only 779. The sensing amplitude is also normal. Let us find out what's happening. If you look at the interval plot here, you see there are some rapid detections here. Some non-sustained episodes you can see here. They are self-terminating. They have not been treated, but you see some fast episodes. And some of them again are as short as 120 milliseconds. It's highly irregular. Some are here, some are here, some are here. It's all over the place. So irregular RR intervals. Some are very, very rapid, 120 milliseconds in this case. So you know that there is a problem in the lead integrity here. When we interrogate the device and looked at a stored EGM in this particular patient during one such episode, you see that you can see RR intervals nicely here. There is no tachycardia here. But between the RR interval, you can see some extraneous interference. This is very typical of electromagnetic interference. It can be somebody may be ironing his clothes. There may be a leakage in the circuit, which the device perceives as an electromagnetic interference. So some kind of an extra cardiac electromagnetic interference is responsible, and there you can see it happening both in the near field as well as in the far field. Fortunately, it is a self-terminating episode, so the patient was not treated for this episode. So this is an EMI. So what is the summary in this particular case? A lead integrity alert is triggered by meeting 2 out of 3 criteria. Abrupt change in lead impedance is one criterion, which did not happen in this patient. Short interval count. I told you short interval meaning like 150 milliseconds. More than 30 such short interval counts in 3 days is one of the criterion to call it a lead disintegrity. 2 or more high rate non-sustained episodes is another reason to call it lead disintegrity. If any 2 of these 3 criteria is fulfilled, it will give an alert due to a lead integrity alert, and that is exactly what this patient got. The lead integrity alert in this case was due to an electromagnetic interference. The case number 4, a patient with a dual chamber ICD with an RV lead integrity alert programmed on. Like the previous patient, it has been programmed on, came after frequent shocks, an alert from the device. These are the RV lead integrity alert. I just wanted to take you through how you program the RV lead integrity alert on. If you click on this, it becomes on. So if you want the RV lead integrity alert to be on, you have to program it. It is not a nominal setting, you have to program. If you look at one of this stored EGM in this patient, RV tip to coil. RV tip to coil, I repeat, it is a near field EGM, and that is what is used for sensing the arrhythmia. A far field EGM, the coil to the can is a far field EGM. You see there are some rapid activity here in the near field EGM, but the far field EGM is very clean. And the near field EGM is used for sensing, and it comes in the fibrillation range. And that is why it is classified as a fibrillation. Alright? And if you look at this interval plot here, there are multiple episodes in the VF range needing multiple shocks. You see the EGM, I repeat again, the near field is full of disturbance, causing the so-called detection of fibrillation, but the atrial EGM is very clean, but the near field EGM is completely full of noise here, which comes in the ventricular fibrillation range. So fibrillation is detected and fibrillation gets treated. And that is why this patient had multiple shocks. So if I ask you the question whether these are appropriate shocks or inappropriate shocks, the answer is clearly inappropriate because you do not get this kind of a pattern in ventricular fibrillation. It's very typical of noise. If you also have the luxury of seeing the far field signal, the far field signal will be very clean here. So that is why this patient had this lead integrity warning in the first place. So to summarize this particular case, multiple inappropriate shocks due to lead noise. The lead integrity alert was programmed on, which helped in understanding the problem on quick look itself. How do we avoid inappropriate shocks due to lead noise? In today's, I've already introduced this concept. I'll go through it in the next 1 or 2 minutes. How do the current generation devices discriminate noise and abort therapy, unlike what happened in this unfortunate patient? This patient had multiple shocks because it was treated as VF when actually there was no VF, it was only noise. But today's devices can differentiate noise from VF. You look at this. Here, this device, the current generation device, has clearly identified this as noise. This letter annotation, it has been sensed as a ventricular fibrillation because of the near field activity being so rapid. But the device smartly says, though it comes in the fibrillation range, it is not fibrillation, it is something else, it is noise, do not give therapy. And so this device has aborted therapy because this device has rightly classified this as noise. How does this happen? Let us look at this. This is the near field EGM and this is the far field EGM. The near field is full of noise, the far field is very clean. So the discordance between the near field and the far field is taken to advantage to say that it is not VF. If it is VF, the far field also should show the same VF, isn't it? So the very fact that only one of the fields, that is the near field, shows the tachyarrhythmia, but the far field is clean itself, tells you it is an artifact. That's also shown in this very clearly. The near field EGM is full of abnormal signals, and the far field EGM from the coil to the SCC, the coil, the ventricular coil to the SCC coil in this particular instance is very clean here. So there is a discordance between near field and far field. So the far field is used for sensing. It has been marked as fibrillation sense. But this device will rightly classify it as a noise because of the discordance between the near field and the far field. And therapy will be aborted. If you look at this example, this is Secure Sense, which is a trademark of St. Jude lead. I just took this slide to tell you the concordance between near field and far field. Near field, far field also shows the ventricular arrhythmia. Near field also shows the ventricular arrhythmia. There is a concordance between the two. So for both the near field as well as the far field. So this is true VF, and rightly the patient has been given a high energy shock here. If you look at this, the near field EGM shows pulses of very rapid activity. But look at the far field EGM, it's very clean. So this has been classified. Though it is classified as VF, therapy will not be given because of the discrimination algorithm which is available for this particular device. And St. Jude calls it Secure Sense trademark. Medtronic calls it by some other name. But the fact of the matter is, far field being clean and near field with lot of non-physiological signals is correctly classified as a noise. The patient gets an alert, go meet your physician, there is a problem in your lead, but the patient will not get a shock. And as I told you, far field EGM is conventionally the coil, the RV coil to the SCC coil or to the CAN to the RV coil. One of these two are used for far field sensing. And you can also program the noise alert on. When the patient gets a noise detected by the device, he will get an alert. He will not get a shock. He will get an alert which will prompt him to come to the clinician, because the clinician can quickly change the lead, revise the lead. So this is again to show that how the alert comes. The RV lead noise gives an alert to the patient, and when you interrogate the device also, the alert comes to your screen. And this I already told you, the discordance between the near field and the far field, and the waveform has been suspended, the therapy has been aborted here. Case number 5, this is the CRT defibrillator implanted in November 2007. During routine follow-up, there is an interesting observation. What is the consequence of this interesting observation, and what is the solution? If you look at this interval plot here, I will again revise you. The blue boxes are the atrial, the PP intervals. This is one P interval, this is the next P, this is the next P. Consecutive P waves are being recorded here. This is the ventricular, each ventricular electrogram is marked as a point here in this interval plot. You see here, there is something very interesting. For every ventricular activity, there are a set of 2 atrial EGM lines here. This is called a typical railroad pattern, something like the 2 rails. If you see this in the atrial channel, you should suspect far field sensing of the R on the ventricular channel. It cannot be an atrial tachyarrhythmia, because if it is an atrial tachyarrhythmia, let's say somebody may say it's an atrial flutter with 2-to-1 conduction. If that is the case, it has to be in a single line. You won't have 2 lines here. This clearly tells you it is non-physiological. It's a far field ventricular sensing by the atrial channel that is responsible for this typical railroad pattern. As you can see here, this is the atrial EGM that I have shown on top. This is the ventricular EGM. You see here, this is the atrial activity here. Along with the R wave, you see another signal here. So this is the sensing of the ventricular activity on the atrial channel. You can use the word double counting in the atrium. One is a P, the other is a small r from the ventricular activity. The lead may be in close proximity to the tricuspid valve. Sometimes in the annulus itself, you can get this kind of a far field R wave sensing on the atrial channel. But what is interesting is, keep in mind, this kind of a railroad pattern in the atrial channel, you should suspect far field R wave sensing on the atrial channel. What can be the consequence of this? This particular case highlights what can go wrong if this far field sensing happens in the atrial channel. If the atrial channel does not know whether this is a P or a far field R, it will count it as one atrial activity. The next is another atrial activity. This is another atrial activity. This is the next atrial activity. So there will be an atrial tachyarrhythmia possible detection on the atrial channel, which can mode switch, and it can become a DDDI mode or a VVIR mode, as the case may be. This happened to be a very athletic person, and whenever he ran, he had a complete heart block, he had an upgradation to an ICD because of a resuscitated DF. So he has a pacing indication as well as an ICD indication. And when he was playing games, when the sinus rate becomes very fast, the far field R sensing leads to double counting in the atrial channel, and it can be mistaken for an atrial arrhythmia like atrial fibrillation or atrial tachycardia. It can switch mode, and suddenly the rate can come down. The patient can lose AV synchrony, and he can become very fatigued during the game. So this is to show that a far field sensing of an R in the atrial channel can mode switch into a DDIR mode where there is no atrial tracking, and so this patient can get fatigued. And this can be programmed by increasing the post-ventricular atrial blanking period. Mukund, can I take 5 more minutes? Mukund?
Yes, sir.
Because
Yes.
allotted time
Yes,
is
sir.
only 1 hour.
Yeah, 5 more minutes should be fine, sir.
So we will see one more case and we can stop. As I told in the beginning, we can go on and on with multiple kinds of problems. Maybe Medtronic may be kind enough to have one more session for continuation of this kind of a presentation, so that we don't overload the audience with too many points in short time when it becomes completely meaningless. I would like to show 5 points and all 5 to be remembered, rather than show 50 points and forgetting all the 50. So we will end with this case. There is a case number 6, a CRT defibrillator once again implanted in the year 2006. Patient received one shock the very following day. Today the patient was implanted, the next day the patient had a shock. The patient was not symptomatic prior to the shock. The patient, when you interrogated the device, you find that 6 VF episodes have been stored in the data. 5 of them fortunately were non-sustained and 1 was sustained enough to receive this shock. Let us see what happened to this patient. This is the interval plot. This is sinus rhythm happening here. The atrial rate and the ventricular rate are the same, which you expect in sinus rhythm. Suddenly what do you see here? The atrial rate continues to be slow. Suddenly you see very abnormal, all around the place, unphysiological ventricular sensing happening here. So whenever this kind of a thing happens one day following the implant, it is likely to be something technical. It is unlikely to be a lead fracture. It can be a lead displacement, or it can be a loose connection between the lead and the device. You call it as a loose set screw. So you should suspect that. Unphysiological signals happening all around the place. Some are very, very fast to the tune of around 150. As you can see here, it's all scattered all around the place. When a ventricular fibrillation will never have this kind of a scatter on the interval plot. So this kind of a scatter itself tells you that you are dealing with some artifact. Unfortunately, this patient received a shock for an inappropriate reason. This is not a true ventricular fibrillation. This was due to a loose set screw. And whenever something happens on the very next day, suspect something technical, reopen the pocket, reconnect the set screw and screw it more properly this time. This problem will not happen thereafter. And on interrogation, you find that there is a lot of artifactual noise on the near field EGM, which has been sensed as a fibrillation. This is a loose set screw because it is one day after an implant. So Mukund, I have SVT, VT discrimination and multiple other things. I'm intentionally not going into that. I request Medtronic, if possible, to have some other speaker or me or whatever, or even Mukund for that matter, to continue some of the extra troubleshooting, how the current generation devices differentiate between SVT and VT, both in single chamber devices as well as in dual chamber devices. I will stop by saying that we introduced a few concepts about how a device functions, the various zones for the detection of a device, the various therapies that you program, the value of stored data, looking at the EGM, the near field signal, the far field signal, how a noise can be differentiated by looking at abnormal things in the near field and a clear far field, and some problems like a far field R sensing of an atrial lead and a loose set screw immediately after a device implantation. I'll stop there and I'll take questions, and you can also join the discussion. Thank you very much for your kind attention, and I thank Medtronic for the opportunity once again.
Thank you, sir. Thank you very much. Questions, shall I read it also?
Yeah, please. You also can help me in answering some of the questions.
So the first one, sir, when we should opt for single chamber or dual chamber, or single coil or dual coil, any criteria?
To answer the second question first, the SPC coil does not have any great advantage in today's time. Previously, we had issues with low energy devices and high defibrillation thresholds, where you can actually stream these vectors. You can use both the coils, you can use the CAN, multiple vector combinations are possible. In today's time, with modern devices with high energy capabilities and the more stringent detection and therapy criterion, etc., the SPC coil is not a very useful option. So not only that, during the time of extract, let's say this patient comes with an infection 10 years down the line, it is in the coil level where there is maximum adhesions. So in the SPC coil, there will be severe adhesions between the lead coil and the SPC itself, and extraction becomes very technically difficult should there be a reason to explant the device during follow-up. So for the reasons that I told you, a single coil is what we prefer these days in most of our implants. What was the first question? When to use a single chamber device versus a dual chamber device?
Yes, yes.
When there is a bradycardia indication, let's say a patient has got sinus bradycardia, you expect the patient to need also a pacing backup along with an indication for an ICD. I will prefer a dual chamber ICD because you can have the luxury of having an AV synchrony by having an atrial based ventricular pacing. So if there is a Brady indication, I will definitely opt for a dual chamber ICD, number one. If the patient has got significant atrial arrhythmia burden, lot of multiple documented episodes of atrial tachycardia, atrial flutter, so on and so forth, the addition of the atrial lead will help in discriminating between supraventricular tachycardia and ventricular tachycardia, which I've purposely not gone into that because of want of time. So if a patient has got a bradycardia indication, significant atrial tachyarrhythmia burden, I would definitely prefer a dual chamber ICD as opposed to a single chamber ICD. For example, a patient with HCM, there is a high chance of the patient developing atrial fibrillation in future, I may prefer a dual chamber ICD. But if somebody can afford, because the SVT DT discrimination is a lot better by having this atrial electrogram, that if cost is not a concern, a dual chamber ICD is probably the preferred choice. If somebody has only a VF indication, no bradyarrhythmia problem, no atrial tachyarrhythmia issues, he has cost concerns, I will put a single chamber ICD. You want to add something to that, Mukund?
I agree with you, sir. Only thing, having said that, there is no study to date to prove superiority of dual chamber ICD over single chamber ICD. Nonetheless, it gives us another port of electrogram so that we can analyze the arrhythmia signals ourselves. So what went wrong can be better delineated. Second thing, regarding SVC coil, perhaps I will consider that in a patient with hypertrophic cardiomyopathy where the ventricular mass is high, and so that we can get the additional choice of shocking vector. And in right-sided implants, where some left-sided venous issue or infection has happened, and you are forced to implant the ICD on the right side, in that case also I will consider a dual coil lead.
Absolutely.
That's
For better vector, for better shocking vector.
Yes, sir.
Because as Mukund correctly said, the can in the right side implant is on the right side. So if you also have the luxury of having an SPC vector, there can be more myocardium which will be coming in the vector for a better shock efficacy, as he correctly said. I fully agree with what Mukund said. Yeah. Any other question, Mukund?
Yeah, one more, sir, is does changing the sensing polarity to integrated bipolar affect the detection of VT or VF compared to dedicated bipolar?
The dedicated bipolar means there is only a tip electrode and a ring electrode for near field sensing. Integrated bipolar means you can also use the coil and the tip for near field sensing. That is called the so-called integrated bipolar. So the coil also becomes part of the sensing vector. So as I told you, a particular case, you have the luxury of reprogramming one to the other if one doesn't have a good sensing amplitude. But having a coil as a vector also has a disadvantage. If the coil is close to the tricuspid valve, it can pick up atrial signals, etc. So if it is deep in the ventricle, a large dilated right ventricle, this kind of a concern is not there, and the distal tip to the ring sensing amplitude is not up to the mark, I will definitely use the tip to the coil. Having said that, if you take Senju devices, for instance, they don't even have this integrated bipolar available in their armamentarium. It's only distal tip to the ring. So, barring that, using that to your advantage in a given case where tip to ring is not good sensing amplitude, I don't find any extra advantage of the integrated bipolar. And Mukund, you want to add something to that?
I agree with sir. I agree. Sensing is to the myocardium when you use true bipolar, because the proximal ring is more close to myocardium, whereas in integrated bipolar it may be a bit proximally floating in the blood. Advantage that you get additional vector. That's all, sir.
Any other question, Venkat?
No, sir, questions are that much only. So, a couple of comments to arrange the continuation session and to arrange another class where Natarajan sir.
I'm very happy to know that somebody has also, not that they've invited me to give the second talk. I'm very happy that somebody has understood what I meant by saying not to clutter too many slides. We can go on and on. Mukund can talk for 3 days continuously on ICD troubleshooting, I'm sure. It is not there. The idea is to convey a few meaning, concrete in the especially lot of PGs are listening to our presentation. One of myself or Mukund or somebody of your choice will be more than happy to continue this session for another 1 hour for ICD troubleshooting. Thank you very much, Medtronic, and thank you, Dr. Mukund. It's a pleasure to have you as a chair in this session. I'm very honored to have this session. So thank you very much, and we will see some other day. Thank you very much.
Yes, sir.
Thank you, sir.
Have a nice weekend, sir. Bye.
Thank you. Bye.
Thank you, sir. Thank you. Thanks a lot for the valuable presentation. Thanks, Mukund, sir, for being. Thanks also to Dr. Sundakar. Thank you all.